Welcome back to the Mayo Clinic Cardiovascular Podcast Series, Interviews with the Experts. I'm your host, Dr. Sharonne Hayes. I'm a non-invasive cardiologist and Vice Chair of Faculty Development and Academic Advancement for the Department of Cardiovascular Medicine here in Rochester, Minnesota. Today, I'm joined by Dr. Ammar Killu, who is Associate Professor of Medicine in the Division of Heart Rhythm Services, where he leads trials and innovations in that division. He's also here in Rochester. Welcome, Ammar.
Thank you very much. Excited to be here with you.
Well, I'm excited for our topic today, which is updates and left atrial appendage closure. So our patients are increasingly medically complex with increased burden of atrial arrhythmias, anticoagulation concerns, advanced age, multiple comorbidities, and the decision-making for stroke prevention has also become increasingly complex. So today, we're going to explore with you the expanded indications for left atrial appendage closure. We're going to learn about from you how to select individuals that may benefit from left atrial appendage occlusion and really better understand options and major differences between currently available commercial devices. So I'm looking forward to this conversation.
Likewise, thank you.
So let's start with the basics. What is left atrial appendage closure? Why would we be thinking about it for our patients?
Yeah, it's a very good question. So left atrial appendage closure is essentially a procedure whereby we're closing off the pouch-like extension of the heart that is in the left atrium, which we call the left atrial appendage. And the reason that is done is to reduce the risk of stroke in patients with atrial fibrillation. As we know, in atrial fibrillation, you get insufficient contraction of the left atrium and the left atrial appendage. And, not to oversimplify the process, but this results in stagnant flow. You get clot formation and therefore the potential for thromboembolism and therefore stroke. And we know from prior studies that in patients with atrial fibrillation, about 90% of blood clots that form within the left atrial appendage. And hence, that's why we target the left atrial appendage for closure to prevent stroke in these patients.
Anticoagulation is the mainstay of treatment, but obviously we all have patients who can't tolerate, they have bleeding, they don't want it. So those are obviously potential candidates, but who are the best candidates? Who's going to benefit most from atrial appendage closure?
Yeah, so patients who have what we used to term non-valvular atrial fibrillation, so that excludes patients, for example, with mechanical heart valves or significant, greater than moderate to severe mitral stenosis, for example, who have an elevated risk of stroke. And typically we utilize the CHATS-VASc score of more than 2. And it's those patients who are at higher risk of stroke, but also have an intolerance to long-term anticoagulation. So either they, for example, have had a major trauma and are at risk of recurrent bleeding, or have had major GI bleeding, non-amenable to intervention. They may have cerebral amyloid angiopathy or prior intracranial bleeding. So those are really the patients who derive the most benefit because they're still at higher risk of stroke, but unfortunately, their risk of bleeding with anticoagulation is great as well.
Yeah, it's also high. So have there been any recent expanded indications for left atrial appendage closure?
Most patients would fall under the umbrella of having intolerance to long-term anticoagulation. I have to, be honest, in clinical practice, that's a very broad definition. While, the procedure, I think, best serves those with high risk of bleeding or history of bleeding, it has been expanded, to patients with liver disease, low platelets, those kind of things. Occasionally, we'll be referred patients where there is a drug-drug interaction and there's no alternative agent that would work as well for them, and that's why they may be referred. But the guidelines have really kind of moved. Before left atrial appendage occlusion, at least in the HRS guidelines, was a 2B indication, but now it's been promoted to a 2A recommendation in patients who have a contraindication to long-term anticoagulation for a non-reversible cause. Interestingly, patient preference to avoid anticoagulation is now a class 2B recommendation based on the latest guidelines.
Yeah, I certainly, when I am in our community cardiology clinic, that is often they've read about the procedure. They're either afraid of anticoagulation or tired of anticoagulation. And so it is not now completely unreasonable for me to refer those patients for consideration at this point based on current guidelines. So, what devices are the options when you're deciding what you're going to put in? What are your choices?
So currently in the US, we have two approved devices. The one that was approved first was a Watchman device, and that one is a Boston Scientific device. It was approved in 2015. That has undergone several iterations over the years. So from the Watchman device, we had the Watchman Flex and now the Watchman Flex Pro. Basically, the changes have resulted in greater procedural safety, efficacy, and also it's allowed us to treat a greater a breadth of anatomical variation. So, for example, with the Watchman Flex Pro, we can go from the device size comes from 20 to 40 millimeters, which allows us to treat, appendage ossia from about 14 to 36 millimeters. And prior to that, we were restricted in some of the smaller and larger appendages. The other device that's approved is the Amulet device manufactured by Abbott. Whereas the Watchman device is a single lobe device, the Amulet is a lobe and disc device. This one was approved in 2021, and it comes in various sizes as well, from 16 to 34 millimeters, but covers appendage ossia up to 31 millimeters. The difference is that the Amulet really doesn't require much depth in order to be able to deploy it. And so it may be suitable for patients with very shallow appendage openings that then kind of have an acute takeoff. Though I have to say, with the modifications in the devices, it really has expanded the variation in anatomy that we can successfully treat. There is one other device, whereas the Watchman and Amulet are both endocardial percutaneous devices. The Lariat device is both endocardial and epicardial suture-based device that has a 510(k) approval. And that was approved way back, I think, in 2006. But it's not as commonly used as the other two devices.
So it sounds like from a procedural standpoint, there would be probably a device that you could identify for almost anyone, or the majority of patients.
Yes, absolutely. And we see this in clinical practice as well as in the prior studies that are being performed. There is a very high likelihood of procedural success. But of course, we're not just defining success of the procedure, by being able to deploy the device and it remaining in situ. What we want to do is have complete elimination of the left atrial appendage, or occlusion, I should say, of the left atrial appendage, to not have any peri-device leak, and then, of course, avoid other complications.
And do you, just from a procedure standpoint, use TE guidance as your, or fluoroscopy, or both, or how do you define success in the procedure?
Yeah, that's a very timely question. So I would say around the country, most of the procedures are guided with TEE. In our institution, we do most of our procedures with intracardiac echocardiography, so ICE guidance. And we do that by placing the ICE catheter within the left atrium directly. And so we have very clear visualization to help guide the procedure. But still, if you look nationwide, the vast majority would be with TEE guidance in concert with fluoroscopic imaging as well.
Yeah. So once you put it in, you've been successful. What do we advise the patient and the referring clinician about anticoagulation and antithrombotic regimens early and mid-range after the procedure?
Yeah. So after deploying and releasing the device, patients are typically placed on an anticoagulation or antithrombotic regimen. There are guidelines and approved indications, but I'll preface it by saying that there is considerable variation in practice between individuals where we tailor the therapy really to the needs of the patient. And what we're trying to do is minimize the likelihood of device-related thrombosis, but also obviously avoid bleeding, which is why we're doing the procedure in the first place. So the protocol really varies based on the devices. With the Watchman device, we typically recommend 45 days of either warfarin or direct-acting anticoagulant. And then at 45 days, we'll switch to dual antiplatelet therapy up to the 6-month time point. And following that, it will be single antiplatelet therapy, typically with aspirin. But again, wide variation that you'll see. With the Amulet device, typically patients will do 6 months of dual antiplatelet therapy, and then after that, they can discontinue it. The Watchman device is also approved for 6 months, for dual antiplatelet therapy from the get-go as well. But we still typically recommend continued antiplatelet, single antiplatelet therapy at the 6-month time frame.
And so were you saying that with the Amulet device, you stop all antiplatelet therapy at 6 months?
Yes.
So, okay. So it's done.
Typically, yes. We do perform imaging typically between 6 and 12 weeks after implantation, and then again at 1 year to evaluate the device, make sure that there's no significant leak, no device-related thrombus, things like that as well, which may require a change in therapeutic strategy.
So are there newer devices on the horizon? What do you see happening in the near and short term or you're excited about?
Yeah, so we're kind of at this inflection point, I would say, within our field. So as we discussed earlier, the patients that really underwent left atrial appendage occlusion were those with high risk of stroke and, history of significant bleeding. What we've seen from numerous studies moving forward is kind of this move towards patient indication expansion. And so there are a few studies on the horizon that I think may change the landscape of how we practice, and I'm eagerly awaiting the results of those. And, the questions that they'll help answer are, can patients who are tolerant of anticoagulation undergo left atrial appendage occlusion and have favorable outcomes? Can you perform left atrial appendage occlusion at the same time as catheter ablation for atrial fibrillation? And then allow patients to come off anticoagulation longer term without having a higher risk of stroke. And so studies like the OPTION study, the CHAMPION study, CATALYST, those kind of things will all provide further information. There are many, many devices that are on the horizon. Perhaps the closest one to the US market is one called the Laminar device. And this one, it's an interesting device, and I'm looking forward to seeing it in action. Essentially, we're part of a clinical study, or will be part of a clinical study evaluating its use. And it's a device that basically has a ball and lock feature that rotates and closes off the left atrial appendage. And the reported benefit of it is that it has a small surface area and therefore theoretically minimizes the likelihood of peri-device leak and also device-related thrombus. And so excited to see how that one pans out.
Are there reasons that our colleagues who are watching this podcast may want to reach out to you and get those updates? Is our volume high here at Mayo Clinic?
Yes, we have a good volume here, a lot of referrals, both de novo patients, but de novo referrals for closure, but also patients who may have failed closure elsewhere. We're always very happy to evaluate patients and help as we're able to. We'll occasionally see patients as well who have undergone appendage occlusion, but have had a suboptimal result with either a leak or something like that that requires intervention. So certainly very happy to see anyone that referring providers may feel that we would be of assistance to. And then, of course, if anyone is interested in being part of any of the clinical studies that we participate in, we'll be more than happy to see them.
Well, thank you. I've learned so much today. Thank you very much for joining us.
Thank you for your time.
This wraps up this week's episode of Interviews with the Experts. I'd like to thank Dr. Killu for joining me today and discussing this really important topic. We look forward to you joining us again next week for another Interview with the Experts. Be well.